basically left lower quadrant cramping plus diarrhea in a patient who is hospitalized. Everyone's gonna jump at this, I know. What's the diagnosis here? Any idea with this? I'm surprised no one jumped at this. C. diff, exactly. C. diff. Okay. Let's talk about C. diff a bit. Okay. So C. diff is basically like a gram-positive rod. It's basically spore formers, anaerobic. Okay. Then it's toxins. Toxin A is basically, it causes mucosal enterocyte damage which leads to diarrhea. Okay. Toxin B basically disintegrates actin which leads to protein synthesis problems, and you form a grayish exudate over the colon or over the mucosal surface. Okay, so the risk factors for C. diff, number one is recent hospitalization. Then the second risk factor is basically PPI use. Third is basically recent antibiotics use, particularly clindamycin. Okay, complication to be worried about is what is the complication to be worried about with C. diff? Toxic megacolon. Excellent. Okay, so what if I give you a question where patient has C. diff with progressive abdominal, because I've seen this happening in the ICU. A progressive, what was that patient? He was hospitalized, a progressive abdominal distension, and patient now complains of sudden onset severe abdominal pain. Examination is significant for guarding and rebound tenderness. What's the next best step in management? NBSIM means next best step in management. So what's the next best step in management? What happened and what do you want to do for this patient? Get a plain X-ray abdomen. This will show air under the diaphragm because the toxic megacolon has perforated. Okay, buzzwords for perforation or peritonitis. Okay, because perforation leads to peritonitis, obviously, is basically guarding, rigidity, and rebound tenderness. Okay, whenever you see these three things on abdominal examination, whether it's a perforated peptic ulcer disease, perforated toxic megacolon due to, let's say, ulcerative colitis, perforated bowel due to toxic megacolon secondary to C. diff, it's all even due to traumatic perforation like an RTA patient. If you see guarding, rigidity, and rebound tenderness, you're going to be thinking more along the lines of perforation, and you're going to get an X-ray. So the management is something like get an X-ray. Yeah, obviously. So basically, whenever perforation is going to be happening, you're going to be giving the patient IV fluids and antibiotics. That's like given, because whenever you see a patient, you always have to address A, B, C, D, E, airway, breathing, circulation, disability, everything else. Okay, so I'm talking about what you do after resuscitation, because if you don't resuscitate the patient, they're going to die in the X-ray room. Okay, so I'm just going to add to it IV fluids plus antibiotics. X-ray abdomen. X-ray abdomen shows air under the diaphragm. You're going to be get the patient to the OR and go for exploratory laparotomy. So like get your scalpel out and like, I don't know. Okay, let me show you a picture of air under diaphragm. So this is typically, so this is something usually some people refer to it as a crescent sign because it looks just like a crescent. Okay, like this. Okay, so this is what we call as the air under the diaphragm. So you see, these are your diaphragms, and remember the right diaphragm is more elevated compared to the left because on the right you have your liver. Okay, so this is basically this small section that you see. This is air under the diaphragm, and this is indicative of hollow viscous perforation. Okay, is this clear? Is this clear? Okay, then treatment for C. diff. What do you want to go for? What do you want to go for? Oral Vanco. Now, if you said oral Vanco, why use an oral Vanco? Like 90% of the time I've seen we use IV Vanco. Why oral Vanco? Why oral Vanco? Okay, exactly. So this is something I've written in the high yield one-liner series. So I'm just gonna copy paste it here. Okay, because I've written it very basically and simply. Okay, so the idea is that basically oral vancomycin, whenever we're going to be giving some patient vancomycin, it's always going to be IV because oral vancomycin has terrible bioavailability. Bioavailability is basically defined as the amount of the drug that actually reaches the circulation after absorption. So terrible bioavailability basically means that very less amount of the drug is going to the blood and more of it is staying in the GIT. Okay, clindamycin is something that causes C. diff. Lana, clindamycin is something that causes C. diff. Okay, yes, fidaxomicin. You're going to use fidaxomicin, vancomycin, or metronidazole. Okay, from what I've seen at the hospital, my attending loves using metronidazole. Okay, for C. diff. So basically the idea is that if it's going to be staying in the GIT instead of going into the blood, you can basically take advantage of that by basically seeing that the C. diff is within the gut. Okay, remember C. diff is not normal GI flora. C. diff is not normal GI flora. So if more oral vancomycin remains in the GIT, it's going to kill off more of the nasty bugs.